Hello, friends. Welcome back to our Back to Basics series on Antidepressants Mechanism of Action. So, as many of you know, I am doing this 3 lecture series on this topic. We just did our first lecture on serotonin, basic and beyond. If you have not watched, please do watch that. I will place the link below, and you can also click on this link back to basics.subscribemenow.com for more details. But today we are going to discuss the second topic with mechanism of action for SSRI, SNRI, NDRI, tricyclic antidepressant, and MAOI. To make it more simple, I will discuss this lecture in 10 topics. So let's begin this topic for today on mechanism of action for these medications. So first topic for today is SSRI's mechanism of action. Well, we know that SSRI stands for Selective Serotonin Reuptake Inhibitors. And we have many medications right now in this class, total of 6. Fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, and escitalopram. Now, how does this class of medication work? Well, we know by the name that they block the serotonin reuptake transporter. What does that mean? Well, I think you remember that diagram that I made in our lecture number 1. We discussed detail of this pathway. So the serotonin reuptake transporter is here. So SSRI medications, they block this transporter. So what happens is serotonin is not taken back, but it starts to increase at the synapse level. But it also increases in other areas of the neuron. And that's actually our question number 2 for this topic, which is, why does antidepressant take this long time, 3 to 4 weeks in most cases, for onset of response? It's a little complicated, but I will try to explain this here. So let's go back to that diagram. So when any medication that blocks a transporter, it affects not only the synapse level, which is axonal level, but it also affects on top somatodendritic area of the neuron, which is on top, little far. So let me actually go down. Yes. So blockage of transporter increases serotonin first on top, which is the somatodendritic area, and with time it increases serotonin at the synapse level. So why does it matter where serotonin is increasing? Well, it matters because when serotonin is increased in a somatodendritic area, it first acts on these alpha 2 receptors. What are alpha 2 receptors? Well, alpha 2 receptors are autoreceptors. They are like a brake. What that means is when serotonin increases in that area, it acts on alpha 2 receptors, and it acts as a brake for serotonin synthesis and flow downstairs. So if there is more serotonin, more action on alpha 2 receptor, less serotonin will flow down, less serotonin in the synapse, so nothing will be positive. But brain is very plastic. What that means is, with time, the neuron notices that there is less serotonin impulses, less serotonin flowing down. So what happens is these alpha 2 and other autoreceptors, they downregulate. And you see 5-HT1A is also there, which is also similarly a brake autoreceptor. So these autoreceptors downregulate. So what happened is there are less brake, more serotonin flows down into the synapse, and then more efficacy, more antidepressant response happen. It all depends on the downregulation time of these autoreceptors for the onset of antidepressant response. So with time, it increases in synapse level also. But be mindful, the synapse level increased serotonin also happens initially, but because of the autoreceptor activation on top, less serotonin is available in synapse. And all of you remember the effect of each serotonin receptor, correct? If not, please watch the first video again. So when little serotonin is available here, it acts on these receptor and thereby causing early onset of side effect from serotonin. That's why we see early onset of side effect in some cases and later onset of beneficial response. Very important clinical point here. So let's move to, so this was our topic number 2 or question number 2 of this lecture series. So question number 3 is, which SSRI also have a dopamine reuptake inhibition effect? Well, this is interesting because we are talking of SSRI as only blocking serotonin reuptake inhibition. Is there a SSRI that also blocks dopamine reuptake inhibition? Well, there is. And this medication is called sertraline. Sertraline it acts on a dopamine reuptake inhibition at a little higher dosages. I will say at 150 milligram or 200 milligram dosage compared to other antidepressants that we have. So very important point here. This was point number 3. Now, moving on to next class of medication, which is SNRI. Now, we have many SNRIs here, which is serotonin, norepinephrine reuptake inhibitors. We have venlafaxine, desvenlafaxine, duloxetine, milnacipran, and levomilnacipran. Now, let's discuss the fourth question here, which is mechanism of action for SNRI. How do they work? Well, the name tells us everything. It blocks not only serotonin, but also norepinephrine reuptake transporter. So you see in lecture number 1, I told you that this diagram will be very helpful. I have made these 2 or 3 neurons in one diagram. On the left is a serotonin neuron. On the right is either norepinephrine or a dopamine neuron. I will repeat again what I told everyone in lecture number 1, that in reality, these neurons are different. They don't exist like this. I have done this only to make these explanations more easier for you. So what happens is, SNRIs, they block both of these transporter. Serotonin reuptake transporter on a serotonin neuron and norepinephrine reuptake transporter on a norepinephrine neuron. So what happens is, again, it increases both serotonin and norepinephrine at both levels, and again it will take 2 to 4 weeks for onset of response for these medications. So this was our question number 4, mechanism of action for SNRIs. Moving on to question number 5, which is, how are venlafaxine and duloxetine different in terms of their mechanism of action? Very important topic, because venlafaxine mechanism changes as you increase the dosage. What does that mean? Well, when you start at 75 milligram or less than that, it acts like an SSRI. So it only blocks the reuptake of serotonin reuptake transporter. But as soon as you go up beyond 75 to 225 dosage, it acts as an SNRI. But if you go beyond 225 milligram, it will also have effect on dopamine reuptake inhibition, but side effect profile increases drastically at that dose. Very important point to be noted for this question, because duloxetine is very different. It acts as an SNRI at all dosages, 30 milligram, 40 milligram, 50 milligram, 60 milligram, 90 milligram, or higher than that. It's a pure SNRI. But venlafaxine is different. I'm not talking about other SNRIs here like desvenlafaxine, which is like an active product of venlafaxine. The main difference is more in the enzyme or cytochrome P450 enzyme that breaks it down. But we are talking more at a mechanism of action level, so I will not go into that. And before we finish the SNRI, be mindful that SNRIs are very helpful in patients with comorbid pain condition compared to SSRIs. But again, side effect profile changes with these reuptake inhibitions. For example, for SSRIs, you will get more serotonergic side effects, which are GI side effect, sexual side effect, bleeding side effect, or increased risk of bleeding, I should say. For SNRIs, you get the similar symptoms, side effects, but you also get a norepinephrine, noradrenergic side effect of activation sometime. But also the risk of hypertension is high, so be very cautious prescribing SNRIs if somebody have uncontrolled hypertension. So moving forward to our sixth question here, which is mechanism of action for NDRI, which is norepinephrine dopamine reuptake inhibitors. And at this point, we only have one medication here, bupropion, Wellbutrin, very important medication. So how does it work? Well, it blocks both norepinephrine and dopamine reuptake transporter. Here is a diagram. So it blocks only the dopamine and norepinephrine one, not the serotonin one. So it increases norepinephrine and dopamine at both levels and thereby causing efficacy. And actually this is an important point here. Knowing these mechanism of action is very important when you augment or add these medication. That's why adding Wellbutrin to SSRI or SNRI will make more sense, because you are also increasing dopamine by this mechanism. So that was our question number 6 regarding mechanism of action. But question number 7 is, how is bupropion Wellbutrin different than other antidepressant? We just talked about it. There is no serotonin reuptake inhibition here. It's mostly dopamine and norepinephrine with bupropion. But there are some other difference, which is no or less risk of sexual side effect. Like in lecture number 1, we talked about the sexual side effect and serotonin receptors. Because bupropion don't act on those, the risk is very low or not there. And there is an increased risk of seizures with bupropion. We have a different lecture on our course. You can go and check for more details. But very important factor, actually a contraindication, if you have a seizure disorder history with bupropion. That's why you don't give it to eating disorder patients because of electrolyte abnormalities. Seizure risk go up with that. But coming back to this topic, what other factors are there that makes bupropion different than other antidepressant? Well, the effect on weight is opposite of other medication. Either there is no effect or some weight reduction noted. That's why you also have this medication, a combination of Wellbutrin and naltrexone for weight reduction. And the last is it's helpful for smoking cessation also compared to other antidepressant. So be mindful of these factors when you prescribe medication. Not only major depression, but you need to be mindful of comorbid psychiatric and medical conditions. So this was our question number 7. Let's move to question number 8, which is actually about tricyclic antidepressants, mechanism of action. We have many tricyclic antidepressants, but now we prefer more newer antidepressants, but these are very, very effective and helpful medications in selected patients. I have only named few here. The list is long. The one that we still use nowadays are amitriptyline, clomipramine for OCD, right? Disipramine, nortriptyline, and doxepine. Doxepine for sleep. We still use it in some cases where other medications are not effective. But how does tricyclic antidepressant work as an antidepressant? Well, they block serotonin and norepinephrine reuptake transporter. So they again work on both serotonin and norepinephrine, and both levels goes up. Again, it takes some time, like 2 to 4 weeks, depending on the downregulation of those receptors. And that's our mechanism. But you will say, well, that's like how SNRIs work. Exactly. So that actually brings us to our next question, which is how are tricyclic antidepressant different than SNRI? Well, the difference is in their receptor profile. Tricyclic antidepressant not only work on serotonin and norepinephrine reuptake transporter, but they also work on other receptors. They are anticholinergic, antimuscarinic, alpha-1, histamine H1 blockage, and also voltage-gated sodium channel. Now, this receptor profile places them in a risky range in overdose because they have a cardiac side effect. They are not indicated, or I should say, you should avoid them in elderly patients because of this. So because of side effect profile, risk in overdose, we don't prefer tricyclics because we have SNRIs, they work on serotonin and norepinephrine, and we avoid other receptor profile. Just want to add one point here. Be mindful that among SSRI medication, paroxetine have antimuscarinic effect too. So the side effect profile is little high for paroxetine among other SSRIs. So let's come back. So this was our question number 9. Let's finish this video lecture with our last and 10th question, which is mechanism of action for MAOI, which is monoamine oxidase inhibitors. Very effective medication for treatment-resistant depression. I will highly recommend to not, or I should say, please consider them in cases where other medications are not effective. Very good medication, very effective medications. So the medications that we have in this class are phenelazine, tranylcypromine, selagelene. So how does these medication work? They inhibit this enzyme called MAO, which is monoamine oxidase. And I think you will remember from our lecture number 1 that there is this enzyme called MAO here in a presynaptic neuron, and the normal mechanism of this enzyme is to break extra serotonin or destroy extra serotonin. So when you give this medication, what happens is the destruction will not happen, and most of the serotonin will be packaged in a vesicle, will come down, fuse to the membrane, and will be released into synapse and will be available for postsynaptic neuron. That's how MAOI works, and increases the levels at in a synaptic level. So this is the reason why we get that hypertensive emergency or urgency side effect with MAOIs. So think about it. You are eating a tyramine-rich food, which will actually increase the level of norepinephrine and neurotransmitters. But we don't have an enzyme breaking those neurotransmitters. So what happened is there's high level of norepinephrine coming from tyramine-rich food also, and you get hypertensive urgency. That's why you need a diet restriction with MAOIs. Otherwise, they are very, very effective medication. So friends, this was our lecture series number 2, lecture number 2 in this series. The next lecture will be posted this coming weekend. It will be on these two classes of medication, but very, very important lecture. Please go and check this link. I will keep updating our lecture schedule here. It's back to basics.subscribemenow.com. And these are the references. You can click the link below and read more references detail if interested. And this is available on our website, Psychiatry Education Forum. It's available on our YouTube channel. Please subscribe to the channel if not already done. And this is actually available in our course. We have many sections in the course. One of the section is called Back to Basics series. This series I have kept free for everybody. So please do check the link below in the information for more details. But if you have not subscribed already, please do subscribe to the course. It's Physician's Guide for Clinical Psychiatry course. Click the link below for more details. And do join our email newsletter to stay up to date on my new post, new video, new course chapter, and other details. So thank you, friends. Thanks again for watching, listening to this video podcast. I am Dr. Harvinder Singh. This is my email. Don't hesitate. Contact me if you have any questions. So thank you again. You all have a good day. Take care. Bye.